guys are ready.
Things. Yeah, if I miss someone's hand raise or something.
What's that?
If I miss somebody's hand raise or something.
Oh, yeah.
I don't.
I got you covered.
Thanks.
Someone over here while you're like talking. There we go.
I think we'll go ahead and get started if that's okay. I want to thank everybody for your attention today. I'm Dr. Stephanie Firmer, and my specialty is physical medicine and rehabilitation, specifically pediatrics. And I'm working with our team today to present the complex patient exam lecture, and I hope it can be an open dialogue too, and asking questions kind of throughout, and we'll have time for discussion as we go along. I'll start off by presenting Dr. Dottola's slides this morning. So often as a student, you're going to see patients in clinic or on the floor and be asked to see patients who may pose complex issues. Now, what does that really mean? In today's lecture, we're going to go over specific goals and objectives related to the complex patient exam. Hopefully, after this lecture and discussion, you'll be able to understand and be able to apply strategies for interviewing and examining the complex patient. And hopefully, you'll have an increase in comfort level in examining a patient with challenging physical obstacles. And we also hope to introduce and after this lecture, you'll identify common devices that may pose a challenge to a patient's examination, and also to identify and describe wounds and their stages. And what are the different complex patient scenarios we're talking about? Potential scenarios you might see is a patient with different lines or devices, a patient that might use a wheelchair or be on a stretcher. There's patients that have different types of bandages or wounds in all different areas of the body. There's patients with different mental status changes or behavioral or mood issues. So very complex in seeing the patient as a whole patient. They're not just to be referred as the wound in bed 4 or the stroke patient in bed 6. It's the patient with, to consider and make sure that we're aware of these different scenarios. Dr. Dottola wanted to share some comments about his personal experience and patients getting to be examined in a wheelchair. I care for patients that are often presented in my clinic in a wheelchair. Having the experience too as being a student and then a resident and now an attending examining patients in the wheelchair, there might be a different practice or approach that the attending or resident or student may take to that patient that's in a wheelchair or on a stretcher. But you want to make sure that the patient's in a position to have the most accurate exam performed, because you want to make sure that you're treating their needs like you would any other patient, so that you're making sure you're making appropriate evaluation, examination, and diagnosis. So how best to do that? In a complex scenario when you're not sure, ask. This is the time for you to ask questions. I don't know if I really had other attendings maybe bringing up that this is the time to ask questions, and that's something I'd like to share with you. If you have a question, you're a student, and it's good to ask. Ask your resident that you're working with, you're attending that day. Ask the patient themselves. Ask their caregiver that they came in with that day if they had one. Ask the nursing staff you're working with as well. It's always good caution to not remove or disconnect any line or bandage without knowing the consequences, because you don't know if that was a new surgical wound that they don't want the dressing removed yet. You want to make sure that you do your research and do your homework as best you can to take care of the patient appropriately. Sometimes optimal access is not possible with just the way the patient's position. They might be on bed rest that day, and you might not be able to get to see their back exam like you would have. Remember to always wash your hands and use proper PPE as well to protect you and the patient. Any questions about that so far? And we want to make sure that this lecture is very interactive so that you'll get to see different examples of scenarios to kind of walk through and talk through today. So I'm going to present the first patient case of a complex scenario. So case 1, you're seeing a 20-year-old male, they're right hand dominant in clinic. They also have a history of lumbar levomeningocele or spina bifida, and they present to the orthopedic hand surgeon's clinic with a chief complaint of numbness and tingling in both hands. The patient uses a wheelchair for his primary means of mobility. The surgeon performs their history and physical exam and diagnoses the patient with bilateral median mononeuropathy of the wrist. The surgeon's recommending an initial procedure of unilateral carpal tunnel release surgery starting with their left hand. What additional information would you want to know about this patient's social history or functional history related to this case? I'll give you time to kind of think about that scenario and what questions you might ask. You can look at it either way, from the patient's perspective, or if you're the surgeon operating on the patient, what would you want to know to help for a successful outcome? Go ahead. Right, and her question was that you wanted to know what social supports that the patient has because they might not be able to operate the wheelchair the same. And right, you want to know, about that wheelchair setup and do they navigate it mainly with their left hand or their right hand or both, and what type of chair it is. Yeah, good question. Go ahead. Good question. So her question was about what activities do they do in their daily living, if they'd be using their hands, and how that might affect their outcome. Good questions. Any other thoughts? Go ahead.
How will we make the transfer from chair to the other position or patient while they're healing?
No, good question. Her question was about transferring to a different position while they're healing, if they'd be able to do that after surgery. So very good questions. And I think another question is to make sure you understand what is myelomeningocele. So what does lumbar level myelomeningocele mean? And I included a picture of examples of patients with spina bifida where they have a malformation of the forming of the spinal cord or the associated musculoskeletal components like the bones and soft tissues. It could be even as subtle as spina bifida occulta, where there's no obvious maybe physical deformity. You might have a hairy tough patch there, or all the way up to myelomeningocele, where you have the meninges coming out of a patient in their skin and be an open area. So how is that going to affect their function? Having a lumbar level usually means then their functional level lower than the lesion. They might not be able to move their legs as well, so might be very dependent on having the wheelchair for mobility, might not be able to walk. So those are things to just make sure that, I understand this patient from the basic kind of functional level and also just the foundational level. What does that mean? So very good points. And like you talked about, you brought up the good questions. I was thinking from asking a good social history. What is his occupation? Does he drive? Does he live independently or with others? What's his home setup like? So I think you kind of touched on parts of these points for all these questions also, to make sure you have a successful preparation for the surgery on what to expect and what he might have to consider adjusting in his environment to be able to still function. And then you also talked about different questions with like functional history, rated to the primary means of mobility. Is this patient able to use crutches also as well as the wheelchair? Some crutches use the forearms and not push down through the wrist, so that might be one alternative that they might have to use instead of their chair if they're able to, but not every patient's able to do that. Do they have a wheelchair that's a manual wheelchair where they have to propel it with both arms or one arm, or is it a power wheelchair? do they use a walker to help with mobility? So all those things to kind of think about, because if they had surgery, they might not be able to use the walker and push down appropriately as they used to. And then also you talked about activities of daily living. Those are our day-to-day functions that we are able to do, like dressing and bathing. And is he able to live independently, or does he require assistance for day-to-day tasks? Because if he's independent and now is not able to use his left arm, or it's in a splint, his hand, so that might affect toileting, bathing, and feeding. So it's important to ask that. And then, like we talked about the different wheelchair types, I just wanted to show one example of each. This is only kind of the tip of the iceberg. There's so many different varieties. You could have your own lecture just on wheelchairs and mobility devices, but I included a manual wheelchair example on the one side where they'd have to propel using the rim of the wheels. Some have adaptations if they can't use both hands, but you'd have to kind of talk with that patient and see if they have a physical therapist or occupational therapist that is working on those tasks with them, and you can kind of come up with a plan together. Or if they have a power wheelchair, you can kind of see the joystick is on the right armrest. So if they did surgery on the left hand, he would probably be able to still drive with the right chair and right handle for the chair, but the joystick. But what if they had switched it and did the right arm first for hand for the surgery? He wouldn't be able to drive his wheelchair. So you'd have to talk with the patient and see, can they adjust that and accommodate him with the surgery. And then just to kind of go over and prepare so that you're recommending a surgery, for example, if you're the surgeon, you can talk about the risks and benefits of the surgery, but it's also good to think about those higher level questions of what can make the patient successful after surgery. And if you're not sure the answers, it's good to just talk with the patient themselves and their family to kind of get more information. Have a good, work together with a nurse or a social worker or a care manager to help with information, or working with their therapist to help brainstorm and problem solve what we can do to make sure it's a successful outcome. Like we talked about, will they be able to propel their wheelchair if they're in a splint? What restrictions will they have post-procedure? And will they require an alternate home setup arrangement if they're not able to live alone post-procedure? Is there a temporary setup they can have in a skilled nursing facility or in a rehab unit, or have home health come in more often to help with wound care? Other factor with myelomeningocele or spina bifida, they may have trouble with managing their bladder to the point that they need to be catheterized every so many hours. And if they had a surgery like that, will they be able to still do that and have a clean technique? So that was one way you might have home health help with that in the meantime while they're healing. But just a couple things to start thinking about. You're already trying to learn what the actual procedure is if you're going in to be a surgeon, but there's also those other layers that working together as a team can help you make sure that there's a successful outcome for the patient and their family.
Okay, you guys hear me okay? Good, because I'm going to walk around a little bit. So I'm Rob Allison. I am a family medicine doc and have a fellowship in geriatric medicine. So that's an extra year after family medicine residency that I went and did dedicated training to taking care of older adults. So clinically, I see patients from the cradle all the way up through grandmas and grandpas. I also do a lot of nursing home work. So I kind of like it because my day is varied, and before I was here, I could be inpatient seeing a 80-year-old heart failure patient, and then I'd go in the office in the afternoon and see a 8-day-old baby. So it was kind of fun. But what I think is really interesting, and where the geriatric piece comes into complex patients, are that I see a lot of patients that have not only age-related comorbidities, hypertension, diabetes, high cholesterol. Then we get into the geriatric syndromes, which I talked to you guys about last year, the dementias, and maybe delirium. But then we're not all 20 or 30 or 40 forever, and we start to slow down. Or we start to develop issues with the ability to move around. And so we might be in a wheelchair, or we might have to rely on somebody to get around. And if that's not the case, then you end up in potentially a skilled facility or a nursing facility. And so that's where a lot of the complexity that I see comes into play, because they may be debilitated, and then that leads to a whole line of other things that we'll see. So this second patient that we're going to talk about today is 79, and he's got a history of hypertension, hyperlipidemia, diabetes, and Alzheimer's dementia. But he also recently suffered an embolic stroke. And now he's got left-sided hemiplegia. And his wife is 77. She's not in great health. She's frail. So she can't take care of him at home. But this gentleman doesn't need to be in the hospital anymore. There's nothing acute we're doing. And this is the issue that's faced a lot when you guys are on wards, or you may be attending at a different hospital, and this guy's got to go somewhere. Well, where's he going to go? He can't really go home. The children live in Texas and San Diego, and his wife can't take care of him, but he's got to figure out how to get up to the bathroom. He's got to figure out how to feed himself, and he's flaccid on the left side. So oftentimes these patients go to a skilled facility or a nursing home. Now, just a little point of clarification there. Skilled facilities can be also considered rehab facilities. And you may go as any age, 20-year-old that suffered a traumatic brain injury and is getting back on their feet, or an 80-year-old who suffered an embolic stroke, and you're not sure, is this person going to be able to go home? The point is to get you to your maximum level of function to rehab. And so it doesn't mean that they're going to live there. It doesn't mean that they're going to stay there forever. It doesn't mean that your patient at 20 or 30 is going to stay there forever. So just keep that in mind. It can be very scary to go to a nursing home. But encourage them that this is just for rehab. Let's see how you do. And let's get you back on your feet or to your maximum level of function. So then you, as the resident, get a call, and you're notified that his left, spelling error, heel is red in appearance and boggy to palpation. What are you thinking? If any of you were paying attention, it was on the next slide. We had it up earlier. But what else do you want to know about this patient? A few things I would be asking are, does anywhere else hurt? Does anywhere else feel boggy? Is anywhere else red? Specifically on certain parts of the body that we'll talk about. And that's where the physical exam comes in. Every time a patient lands in a nursing home, the nurse should be doing a really good skin assessment. And if you haven't heard about it as the student or the resident, and absolutely as the attending, then we need to do a really comprehensive skin exam, because that is a really important, friable, or very tenuous part of our body when we sit in bed for a long time. And the activity orders that I would be giving, make sure you turn this patient. Get them out of bed. What's the limiting problem here? Well, he's flaccid on the left side. So he can't move that foot. And so that foot just sits on the bed all day, 24 hours a day. And because he's flaccid, he's not getting it up and moving it. And so they get red. They can be really painful. When you push on them, they can get boggy. Okay, but he got there on a Friday night. I'm not coming till Wednesday. And the nursing home is short-staffed. So no one really looked at him. And then he sat in bed, flaccid on the left side for 4 days. And then that quickly, this happens. And we had a really big opportunity to not let this happen. And this is a very common scenario that I see all the time. And these are called pressure injuries. And pressure injuries are a situation where it's unrelieved pressure over skin of bony prominences. And so heels are super easy to think about. You sit in bed all day, you lay in bed, your heels sit on the bed. Now, although it's soft, it's not that soft. And so it's going to cause decreased blood flow. And that decreased blood flow then leads to the lack of viable tissue. And then that viable tissue gets injured. And that's what happens in a pressure injury. And so I really like that slide on the right, or the picture on the right, because we always think about heels. But there are so many other places that we can get pressure injuries. I've seen them on the anterior tibia. Say, why the heck is this happening? Well, they're flaccid on the left, but someone pulled their leg over and crossed their legs, and that pressure on the right anterior tibia got a pressure injury because the person couldn't uncross their legs. And so the pressure of the calf on the left was causing the pressure injury on the right. I've seen them on ears. I've seen them on scapulae or shoulder blades. I've seen a ton on this gluteal region because they turn on one side and they just sit there. So pressure injuries can happen everywhere, and that's why it's so important, not only in nursing home patients, but your patients that are in a wheelchair, your patients that may not have great mobility and just sit around all day in their recliner because it's COVID, they're not getting out, they're 70, and they don't really want to catch this. Well, take a look at their backside. Ask about sores, because these happen a lot, even in mobile people. So there are different stages of pressure injuries. The first stage, as we saw in the very first picture, is red, non-blanching tissue, but the skin is intact. So if you look at the skin, there is no disruption at all, and the skin is red, and when you push on it, it doesn't turn white. That's a stage 1 pressure injury, and I should clarify, it has to happen over a bony prominence. So if that's somewhere else, not on a bone, it's not a pressure injury. It has to be on a bony prominence, the heel, scapula, something that sat on a hard surface caused that decreased blood flow. So stage 2 is the disruption of the epidermis or the dermis. It has not gone into the subcutaneous fat or the subcutaneous tissue. This is an interesting one because we can also clarify bullae, clear fluid-filled blisters, as a stage 2. Clear fluid-filled blisters, stage 2, because you can see the base. You have to be able to see the base on a stage 2. That's the ticket here. You can have that blistering skin is intact, but the epidermis and the dermal layers have separated. Stage 3, now we're down into the subcutaneous tissue, and we start seeing fat is the big one here. Now, there's different layers of fat, and I had a gentleman who was COVID. He was prone for 30 days, and he has a huge pressure injury on his scalp because he was down on the bed for so long, but it didn't go to stage 4 or bone. It was just in the subcutaneous tissue. So remember that it doesn't have to be on your backside. It can be on areas that the skin is thinner, but if you don't see bone, tendon, or muscle, it's stage 3. So stage 4 is obviously bone, tendon, muscle. If you see those, that's a stage 4. Both with stage 3 and stage 4, you can have tunneling, or you can have what's basically the skin is intact, but there's a tunnel or a track. And so if you took a tongue depressor or the blunt end of a swab and stuck it in the wound and kind of went around the edges, you can have that intact skin that's delaminated or disconnected from the subcutaneous layer, and you can have that both in stage 3 and stage 4. There's usually no tunneling on stage 2s. Okay, so last 2. Deep tissue injury. This is a bruise-like appearance over a bony prominence. It can also be a blood-filled blister because you cannot see the base. But usually the skin is intact or that blistered appearance. And again, you may have a blood-filled blister or the skin is intact, but you just have this real boggy, can be tender type of appearance. The problem with deep tissue injuries is that over sometimes 24 to 48 hours, that top layer is gone and it's already a stage 4. And so that's a really big problem. If you have a DTI, we need to offload it. We need to address it because it can progress very quickly. Last but not least is an unstageable ulcer. And this is where there is a very hard, thick eschar, or scab, if you will. It's classic in appearance. It's hard. It's rough. It's kind of the roof of this lesion. It's unstageable, again, because we can't see the base. But it's different because this is an actual kind of hard cap or scab on the lesion. That's technically classified as an unstageable, whereas deep tissue injury almost looks like a bruise. Okay, so those cartoons are great, but let's get into the real thing. What do we see? This is a stage 1. Skin is intact. It's red. If you push on it, it doesn't blanch. Stage 2, you can see, and I like this picture because we can see the differentiation in color. I will also note that individuals with different skin tones, these lesions can look different. So just make sure that you kind of have a feel for I should say that a stage 1 in a darker pigmented skin may look purple. It may look a little blue in hue. That's not technically a deep tissue injury if it's not boggy, if it's not painful. It can be a stage 1. So darker pigmented skin, stage 1s, and deep tissue injuries are a little bit tricky to sort out, and this is where you may want to ask your attending. But classically, stage 1 intact, stage 2 disrupted, stage 3 we start getting to the subcutaneous fat, and stage 4 we're down to the tendon, muscle, or bone. So, traumatic wounds, different than pressure injuries. I don't pretend to be a trauma surgeon. I don't pretend to be an ER doc, and I will warn you guys all right now that there are some pictures here that are a little bit disturbing. But you guys will have to do an ER rotation. You're going to have to do a surgery rotation. So you may have these coming into your ER, your OR, and so we have to at least be comfortable seeing these and understand that these are also complex patients because this is not something that we see in a family practice office, except if you're working where I was before and they'd come in with chainsaw wounds and they cut their finger because they were chopping wood and they didn't want to go to Pittsburgh when I lived south of Pittsburgh and they wanted me to fix it. Different time for a different story for a different time. Let's talk about gunshot wounds. Super important to know what bullet happened. Is it a full metal jacket, which is pretty typical of target shooting or trap shooting? Is it a hollow point? Because these are mainly for self-defense, and there's a difference and a reason why. Or is it some type of pellet or shotgun shell, which has a bunch of compacted little BBs in one shell, and those spray everywhere? Well, why is it important to know? Because the wounds look different. So this is a pretty clean entry wound, exit wound. This is from a full metal jacket. That bullet didn't blow up. Basically, it stayed intact. This, not a full metal jacket. This is a hollow point. Why is this wound a hollow point? Because when you fire a hollow point and it hits something, it flowers. And so this flowering totally macerates the skin, and it's a heck of a lot harder to close. But this can probably be the most interesting and hard to treat. This is a shotgun wound. And all those little BBs are buried in the tissue. So not only do you have to fix the bone, now you got to get all the little BBs out. Not fun. This is why I'm not a trauma surgeon. This is why I'm not an ER doc. This is family practice. This is great for me because this is incredible work, and one of you guys do this, you'll be awesome at it. But I want to give you the exposure now because this can happen. This is something you guys can do, and this is something you might see. Knife wounds, saw wounds, industrial wounds, all a little bit different. The top one, I would call this more of a puncture wound. You need to worry about the vital organs underneath. Was this an abdominal or a chest wound? You need to worry about some type of pneumothorax, some type of vital organ in the abdominal cavity. Is there internal bleeding? Different than the bottom left, which is more of a linear cut on a hand, and you need to worry about tendon involvement. So you need to worry, are they able to open and close their hand because it struck a tendon? So different in even knife injuries. The middle one is a saw wound. This happened to my aunt. This is not her picture, but this is what happened to her. She was helping my uncle redo a house, and she was cutting baseboards, wasn't paying attention, and wham, missing these 3 fingers. Now, luckily, some of them got attached, but she doesn't have great range of motion. Far right, it's called a gloving injury. And this finger got stuck in some type of mechanical process or industrial machine and hit this person's ring and tore the ring with the tissue right off the bone. So these are also complex patients because this is not typical things you may see. Now, again, trauma surgeon, ER doc, yeah, you might see this. But these are also different types of wounds. How do we close them up? Well, something as simple as steri strips are just really sticky pieces of fabric, and you can place over the wound. The whole goal is tissue approximation. Can we get the tissue to line up evenly? That's the goal here. You can do it with steri strips. There's skin glue you could use, but most traditionally in these big wounds are staples and sutures. Staples are pretty easy. You just cha-chunk, 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 cha-chunk. Sutures, they're a lot more involved. There are different types of sutures. There's different techniques. There's dissolvable. There's indissolvable. So the whole point here, again, not that I'm putting a crazy stitch in somebody, but if you're an ER doc and you do a crazy stitch and you stitch somebody up and you send them out and say, hey, I don't need to see you. Go to your family doc in 5-10 days and take them out. Well, then as a family doc, I need to know what stitch they put in. So I'd really appreciate it if you guys write in your note what stitch you did so I know, is it a simple interrupted where I'm just clip, clip, pull, pull, pull each little stitch? Or is it a running stitch? So if I clip one end, I'm going to pull the whole string out? Or is it an even more complex stitch? So there is a blend here of interdisciplinary approaches or collaboration because they don't need to go back to get their stitches out at the ER or the surgeon's office. If you're super busy and you're in the OR as a surgeon, you're probably not going to want to see somebody for a suture removal, especially if they have good primary care. But I need to know what type of stitch so I don't, one, do something inappropriate, but two, I also need to know how many stitches so I don't leave something in. So that's really important too. So the type of suture, the number of sutures, and the technique is very important. So let's take a look at some in real life. These are different approaches and different closures. I want you guys to look at these, and you may have the slide in front of you which has the answer, but which ones of these are normal and which ones of these are abnormal? And so as you look, you don't need to yell it out, but just take a minute and see which ones would you say, that's okay, or maybe I need to call the surgeon. And if I looked at it, the top right is the one that looks the most concerning to me. So you can have a little bit of irritation around the upper left suture. I'd still probably take these out and put this person on an antibiotic. They look a little infected, so it's maybe not the most normal, but you can see a little bit of irritation around a suture that's been in for a long time. So they just couldn't get to you, or they couldn't get in, or they were so debilitated, or they landed in the nursing home and you didn't even know they had stitches in. You can get a little bit of irritation around the suture mark. Same with staples, bottom left. Staples left in long enough can cause a little bit of a local irritation as well. The most normal on this picture is the bottom right. That surgeon did a great job. He everted the edges. That's going to heal up really well. And that's a great looking incision. So that's not a delaminating or a dehissing wound. That surgeon physically and purposely pulled the edges open, left that red tissue around, so when it heals smoothly. So when we cover up these stitches or staples or wounds, there's a lot of different types. Primary and secondary closures are what go right on top of the wound and what wraps the wound. And then you have removable and non-removable. These are all removable types of dressings. If you're in the office, feel free to take these off because we likely have it. So let me rephrase. Check with your office. If they don't have gauze, if they don't have a cling wrap, if they don't have an ACE wrap, either hold on to it if you take it off for the patient or make sure you have it, unwrap it, take a look, especially if it looks like that picture didn't come out. Yeah, the far left. If it's red or the dressing doesn't look good, make sure you take it off and look underneath. That's the big thing in the office we're going to want you to do, is look at the wound underneath if the dressing looks bad. Don't take these off. I don't want you playing with this in a family practice office. Don't mess with these. The one on the left is a wound vac. This is a device that sucks out drainage. It keeps the wound bed fresh. It is permanent, at least for a few days, and then a nurse will come in and change this. External fixator, I've seen these plenty in the nursing home. I don't mess with them. Any drainage, leakage around, right back to the person that put it in because I don't want to mess with it. So external fixators and wound vacs, I'll at least look at. If they look bad, I'm sending back. The other few, I can manage. All right, guys, we'll move on to the next case. Yep.
All right, you can hear me? Okay. I'm Courtney Pilkerton. I'm also in the Department of Family Medicine. And so case 3, so this is a 34-year-old male with a past medical history of Crohn's disease presenting to clinic today, about 2 weeks out from a hospital stay for bacteremia secondary to a spontaneous bowel perforation. You're going in, you're with me in clinic today, and I say, go ahead, I want you to go take a history and do a physical exam. What kinds of things are you thinking you might run into in the room? What kinds of questions do you have? What makes this patient complex to examine? Absolutely. So, do they have an ostomy now? Is it all closed back up? It's clearly they've, how long ago was the surgery? How long were they actually in the hospital? Absolutely. All great questions. What else? Yep. Absolutely. Yeah. There was a bowel perforation. If they were in long enough that they closed everything back up, is everything coming out the way that it should? If they have an ostomy bag, what does that look like? How are things moving? Are they having pain? All of those great questions. What might they have because they had bacteremia that you might also need to pay attention to? All right. So infection. So this is what on exam you see. So you got an ostomy. This patient had an ileostomy for the bowel perforation, so now they have a bag with a stoma. All things you don't just, clearly this is undressed, but when they come in and they have their clothes on, you don't want to just go for an abdominal exam and, whoops, push right onto a new stoma. So paying attention to those kinds of things. Also comes in with a PICC line, needed antibiotics for 6 weeks afterwards for that infection. So you want to make sure that you're checking dressings. You guys talked, Dr. Allison just talked about wounds. Making sure there's no drainage infection, that kind of thing around this "we made it" wound. And then, is the catheter working, that kind of thing. So these are all important. So basically this section is just on lines, tubes, drains. I'm not expecting, none of us are, that you're going to know how to manage every single device possible, but just things to pay attention to when you go into a room. You might not know what patients have. They might not say anything. So you need to be aware that these things exist and how that changes what you can do on an exam. So vascular access, this is one of the first things. We already saw the PICC line. Bottom right corner, you see kind of your typical IV. In the hospital, you may see this IJ, so catheter going directly kind of down to the heart, gives you lots of good access. And then over on the top right, this is a hemodialysis. So they start out really small. They connect the vein and the artery together. You can feel the thrill. You can even sometimes hear the whooshing just from sitting right across from the patient. So if you run into these things, know what's normal, what's not normal. Ask questions. Ask the patient, when did you get this, that kind of thing. They're usually happy to tell you, as well as, just putting that picture together of this patient. So feeding tubes, catheters, and ostomies. So Feeding tubes come in lots of different types. So a nasogastric tube or an NG is going to go through the nose into the stomach. They're usually taped to the nose. If they have to be longer term, you'll sometimes see them go around the ear. All of these things are places that wounds can happen because you've got a pressure of something sitting on something. And so always important to check those things. Clearly you don't want to go tugging on things because they're supposed to be in a particular location. You want to make sure they stay there. And then these are directly into the stomach. They usually have a balloon on the other side so that they don't just kind of come right out. They can be short Mickey buttons. You usually see those in kids. That way you kind of decrease their chances of pulling on them. Or you can see longer percutaneous tubes for feeding. Catheters, you can have nephrostomy or Foley catheters. And so have some examples of these kinds of things. So Foley catheter has a bag, tube goes into the urethra. Some of the bags are big like this. You'll see them hanging on the sides of the beds, hanging off the wheelchair sometimes. For patients who are mobile, they're often a smaller bag that goes on their leg. And they might not tell you about those. So if they have, you need to ask if you see in their chart that they have a catheter. Ask them if there's a catheter in place. I've seen plenty of students and everything. You go to do an exam to check, push up on my leg or whatever, and you put your hand down right on a bag. So again, think about what could be in place on a patient that you need to know about that changes how you do your physical exam. Nephrostomy tubes, so directly into the kidney, you'll often see they're going to be a bandage on the back with a tube coming out. Again, places to think about: how does the dressing look? How does the wound look? What's coming out of them? All things as a student that you should feel very comfortable observing. Some of these you can remove dressings for, some of them you can't. If you don't know what it is and what to do if it unravels, don't touch it. Ask someone else first. That's kind of the rule of thumb. But do ask, because you're going to have to take care of these things at some point, so we want you to learn. So ostomies, so they could be colostomies, they could be ileostomies, they could be any of that. So like in the patient in the example, there's a stoma. So they bring up the part of the intestine and kind of it's on the outside. And then there's a sticker that goes on over it, and then the bag clips on so that you can take the, so then the bag can come off. And so some of these, so the sticker you just cut to kind of fit the stoma through there. The bag will sit on top. Some of them, like this one, are really nice and clear, so you can see right through, so you can see how that stoma looks. You can comment on that back to the attending or the resident that you're working with. You can see what's in the bag. Some people don't like the clear bags because they don't want to have the chance that their shirt pulls up and then you can just see right through there. So there will be basically skin-colored or toned bags, and those are important for you to ask, is it okay? Could you pull the bag down so that we could look at the stoma? If a patient's comfortable with that, absolutely. Those are all things that you can ask them to do. They manage these every day. Okay. So stoma, and then bag goes over. There's usually a sticker. Like this. Some of them are clear, some of them not. All right. And so again, you can see on this one on the far left, you can see really well what's in the bag, the color, the consistency. That one on the far right is a flesh toned for this person bag, so you're not going to be able to see through that. Drains. So there's lots of drain types, and they're all something that you should kind of be aware of. You should be able to manage. So a JP drain, this is often for a surgical procedure that you want to be able to let things drain out. Sometimes it'll be you want to comment on what you see in the drain. You want to, what you see in the tube, is it the same as the drain? Has it been draining? Asking questions of the patient. How long has it been there? When's the last time you changed it? All of those things are great. These are usually attached with a stitch, as you can see on that right picture at the skin. But be careful tugging these, because that's pretty much all that kind of anchors them, is like one stitch usually. So you don't want to, they're usually pinned to your shirt or your pants so that you don't have to like hold them up or anything like that. Sometimes they'll have belts, but you don't want to go trying to take a gown off of somebody so you can do a full exam, or their shirt and those are attached and you're tugging and pulling. So always be aware of kind of what's going on with the patient. Chest tubes. So this is sort of the box piece that you'll see. It'll usually be on the floor if you're inpatient, like in the hospital. They can be set to drain. Again, stitch. These are a little more securely usually attached. Important to pay attention to the colors of things in the tubing. So whatever's in that box, it's being dumped in over days, over hours, whatever. So maybe it changed. Maybe it started out purulent, now it's clear, but it gets all mixed in the box. So what's in the tube will tell you what's happening now. So that's kind of what you want to comment on. Again, these can be really painful. So kind of if you see that box on the floor, ask where your chest tube is, where is it attached, how long ago did it happen, what's going on. All important. So big thing, these all may be hidden. Patients, go home from the hospital if they have lung cancer, but their lungs keep filling up with fluid, so they have chest tubes that they can go home with bags that attach. And most people hide all these under their clothes. You might have a newborn baby who had to have a feeding tube in the hospital because they just couldn't eat enough to gain weight, but they're ready to go home otherwise. So that's all going to be under clothes, under a onesie, those kind of things. So always important to ask, always important to ask about the information that you have. When you're taking a history, think about, oh, they said it didn't gain weight in the hospital. Maybe I should ask about a feeding tube before the exam. Those kind of things. So this is just kind of a do and don't list. Do ask before examining, kind of standard. You guys do that already for patients. It's always good to ask. Check and monitor for patient comfort. If you need to adjust where a tube is, like the JP drain, or you need to move a Foley so you can look at the skin or something in a different area, ask the patient, make sure they're still comfortable. They live with these or they have them for a while. They'll know what works, what doesn't work, what hurts, what doesn't. Consider how recent procedure was. Obviously, a drain that's been in for a long time is going to be probably less uncomfortable than if it's brand new. Observe the surrounding area. This is a great time for you guys to maybe notice the infection starting first, or be able to report back to the team that something's different. Notice the location of devices, status. There will be dates on bandages when they were last changed. Those are all good things to keep an eye on. And then again, any kind of bag, whether it's a Foley bag or a chest tube or a colostomy bag, color, consistency, volume, how often are they having to change those devices. Don't unwrap or open anything without checking with the patient and knowing the consequences. So it's one thing to take the ostomy bag off so that you can look at it, but you don't want to grab from the sticker and peel the sticker part off, because sometimes you might not have those supplies in clinic or the supplies that match with their bags. But the bag part you can peel off. So if you're not sure how that device works, ask the patient, ask the nurse, ask somebody. Tugging or pulling can be really painful, especially if things are attached with stitches. We always think like, oh, of course we know that. And then you go in to do your exam and you're like, I'm going to remember all of the pieces. I've got to start here and I go down. And then in doing that, you sometimes forget like, oh, ouch, you just kind of tugged on something or pulled something, or wasn't paying attention to the patient. You were just trying to focus on, I need to get all these pieces done. Again, don't remove stitches, tape, those kind of things. And don't palpate stomas unless you're trained to do so. So that's something that you'll often see on surgery, but until you're trained to do so, we ask that you don't do that. And if nothing else, from any of this lecture, remember, do not move patient, line, bandage, etc. without the knowledge of the consequences. That's kind of the big thing with complex patients. If you don't know what could happen, don't do it. All right. If anyone has questions, thoughts, if anyone wants to see any of the equipment, stoma, ostomy bag, feel free to check it out.